Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today for our first presentation, we have Megan Szesnat, and she is a PGY2 EM resident at Carolinas Medical Center. And today she's going to be presenting a journal club on Landiolol for refractory VFib.
Hi, everyone. Thank you so much for the introduction. I'm very excited to be here with you all today to discuss this journal article. Before we get started, here are some abbreviations that I will be using throughout the presentation. I'll just give you all a brief minute to review. Okay, first I'd like to start off with some background information. So I'm sure we're all very familiar with the VFib algorithm from the guidelines. So first we give the patient 2 defibrillation attempts. After that, we can start administering epinephrine. And then after the 3rd defibrillation attempt, we can begin our antiarrhythmic agents, namely amiodarone or lidocaine. I do just want to briefly mention that the European guidelines are a little bit different than the American guidelines. And so they actually recommend that you wait to administer epinephrine until after the 3rd defibrillation attempt. And then after that 3rd defibrillation attempt, you can start administering your epinephrine and your antiarrhythmic at the same time. And I just wanted to mention this because the study that I'll be discussing was conducted in Austria. So these are the guidelines that they were following for their protocol. And so now, after we've given multiple defibrillation attempts, we've administered epinephrine and we've administered an antiarrhythmic agent, and the patient is still in refractory ventricular fibrillation, the question kind of becomes, what can we do next? What options do we have? So guidelines don't really have any clear or good recommendations. So they do state that for adults in cardiac arrest, the use of beta blockers, beryllium, procanamide, or sotalol for VFib or pulsus VTach that is unresponsive to defibrillation is of uncertain benefit. And this is a to be recommendation. They don't really provide any further recommendation besides that due to a lack of evidence. And then the European guidelines also don't make any specific recommendations regarding the use of alternative agents in this setting. For the remainder of this presentation, we'll be focusing on the use of beta-1 receptor selective blockade in these situations. And so to be able to understand the utility of beta-1 receptor selective blockade, we first have to understand a little bit more about the mechanism of epinephrine in cardiac arrest. So epinephrine is working on 2 main mechanisms. So we have our alpha-1 receptors and our beta-1 receptors. And so epinephrine works on the alpha-1 receptors to increase vasoconstriction, which increases systemic vascular resistance, which then further increases aortic diastolic pressure, which can increase your coronary perfusion pressure. And then this increase in coronary perfusion pressure can increase your chances of successful defibrillation. And then over on the beta-1 side, so epinephrine through beta-1 agonism increases your heart rate and your contractility, which can then increase your cardiac output, which can be good, especially in the post-ROSC setting. However, this can also lead to increases in myocardial oxygen demand, which can then lead to increases in myocardial ischemia, which increases the risks for arrhythmias. And then additionally, through the beta-1 receptor, epinephrine can increase the hyperphosphorylation of ryanodine 2 receptors, which can lead to an increase in calcium influx, which can cause increased electrical instability, again, further promoting the risk of arrhythmias. And in particular, this can also lower your VFib threshold. So then the thought here with beta-1 receptor selective blockade is that by blocking the beta-1 receptor, we can mitigate some of these negative effects of high amounts of epinephrine. So when thinking of using beta-1 receptor selective blockade in these situations, when thinking about an ideal agent, we want something that is beta-1 selective. So we're only working on the beta-1 receptor in the myocardium, something with rapid onset so we can use it quickly in our cardiac arrest situations, and something that is short acting, because if we have a lot of residual beta blockade after, if we achieve ROSC, this can decrease cardiac output and lead to potential negative impacts. So I'll be discussing 2 main agents, esmolol and landiolol. Both of these kind of fit into our ideal agent scenario. Esmolol has been previously studied, and landiolol is one of our newer agents and is in the study that I'll be discussing in a bit. So when looking at some of the differences between esmolol and landiolol, so they both work very similarly. They both have competitive beta-1 blockade on the beta-1 adrenergic receptor in the heart. They both have a pretty rapid onset, average about 1 to 3 minutes, and they both have pretty short half-lives, with landiolol being just a little bit shorter at about 3.2 minutes compared to 9 minutes for esmolol. But then when looking specifically at the main differences between these two agents, you can really see a big difference in the beta-1 to beta-2 selectivity, with the beta-1 selectivity in landiolol being much higher than esmolol at 255 to 1 versus 33 to 1. And so also some previous pharmacokinetic and pharmacodynamic studies have identified a few other differences between landiolol and esmolol. So landiolol has been found to have a higher potency for heart rate reduction and less potency for negative inotropy. And this is speculated to be because landiolol has no impact on sodium and calcium channel activity compared to esmolol. And then you can actually see in the graph on the right, this is from a pharmacokinetic study in healthy volunteers, just kind of looking to investigate the differences in change in heart rate with comparing 3 doses of esmolol and 3 doses of landiolol. So if you look at the graph on the y-axis, we have change in heart rate, and on the x-axis, we have log dose. And then red and blue, we have landiolol and esmolol. And so as you can see, landiolol in blue led to increased changes in heart rate. And then with further increasing doses, you can see an increasing slope. So this is showing increasing potency for heart rate reduction, especially at higher doses with landiolol compared to esmolol. So now let's discuss some of the previous literature. So there are no specific studies that have looked at the use of landiolol for refractory VFib in the past, but there is this one study that was conducted in 2010 that looked at the use of landiolol in electrical storm. And so they defined electrical storm as sustained VFib or VTAC that occurred either 2 or more times in 1 hour or 3 or more times in a 6-hour period. And they looked at 42 patients in an uncontrolled prospective observational study. So they used doses of landiolol 2.5 micrograms per kilogram per minute, which could be titrated up to a maximum of 80 micrograms per kilogram per minute. And they found that the use of landiolol inhibited electrical storm in 79% of patients. And the mean dose of landiolol that they used was 7.5 micrograms per kilogram per minute. The most frequent effective dose was 5 micrograms per kilogram per minute, and this dose was effective in 85% of patients. Of the 33 patients where landiolol was effective, 25 survived to discharge, and so this was 60% of all patients. And of the 25 survivors, 24 of those could walk by themselves and so had a favorable neurologic outcome, so that's 57% of all patients. This is the closest I could find to using landiolol for refractory VFib. There's been a few other studies using landiolol, but these were all in different settings. There's a lot of data in like perioperative use for SVT, AFib, aflutter, and other tachyarrhythmias. We do have some more data looking specifically at esmolol in refractory VFib. So I found 3 studies here. So the first one was conducted by Driver and colleagues in 2014. They had 25 patients, and this was in an ED setting. They used a bolus of esmolol, 500 micrograms per kilogram, then followed by a continuous infusion. And they were looking at patients in refractory VFib. And so one thing I kind of want to highlight is that some studies have different definitions of refractory VFib. And so this study in particular looked at patients in refractory VFib as those who had an initial rhythm of either VFib or VTAC, had 3 or more defibrillation attempts, 300 milligrams of amiodarone, and 3 milligrams of epinephrine. And so they ended up finding a trend towards increased temporary ROSC, trend towards increased sustained ROSC, and a trend towards increased survival to ICU admission. This was all the same number, so it's the same stat for all of those at 67 versus 42%. And all patients who received esmolol did achieve at least temporary ROSC, and the median time to achieving at least temporary ROSC was 13.5 minutes. They also saw a trend towards increased survival to hospital discharge and discharge with a good neurologic outcome at 50 versus 11%. Over in the middle, we have our next study, which was by Lee and colleagues, looking at 41 patients in out-of-hospital cardiac arrest. They also looked at a bolus followed by continuous infusion of esmolol, and their definition of refractory VFib was similar to the Driver study, They had to have an initial rhythm that was shockable with 3 or more defibrillation attempts. They had to have 300 milligrams of amiodarone and 3 milligrams of epinephrine, and they had to have no ROSC after at least 10 minutes of CPR. And this study showed that there was increased rates of sustained ROSC and survival to ICU admission, both of which were statistically significant at 56 versus 16%. They saw no difference in survival or good neurologic outcomes. And then finally, the most recent study I could find was by Patrick and colleagues in 2022. They looked at 124 patients in out-of-hospital cardiac arrest, and this time they were looking at just a single bolus dose of esmolol. And for their definition of refractory VFib, the patient had to have at least 3 defibrillation attempts. They had to have amiodarone administration and 3 milligrams of epinephrine. And they ended up finding a trend towards increased pre-hospital ROSC at 38 versus 24%. They saw no difference in 24-hour survival or survival to hospital discharge. And then there was actually a meta-analysis that was conducted in 2023 that looked at these 3 studies specifically and pooled their results. And they found that esmolol was significantly associated with a higher chance of sustained ROSC with an odds ratio of 2.95, but they did not find that esmolol was associated with better short-term survival. So then that leads me into why was this trial conducted? So they wanted to first further investigate the use of beta-1 receptor selective blockade in refractory VFib. As I just discussed previously, there's only been a few small retrospective studies, and even throughout all of these studies, we still don't have any hard evidence for long-term survival or neurologic status. And then in this trial, they also wanted to try looking at landiolol instead of esmolol, since landiolol is, again, more beta-1 selective and has a shorter half-life compared to esmolol. So this leads me to the trial that I'll be discussing, which was Landiolol for refractory ventricular fibrillation and out-of-hospital cardiac arrest, a randomized double-blind placebo-controlled pilot trial. So the objective of this study was to evaluate the efficacy and safety of pre-hospital Landiolol added to standard ACLS care in refractory VFib and out-of-hospital cardiac arrests. So they included patients who were aged 18 to 85 years old with an out-of-hospital cardiac arrest, and they had to have refractory VFib, which they defined as at least 3 defibrillation attempts, and the last rhythm had to be shockable. And so of note, compared to some of the other studies that we looked at previously, this definition was a little bit different since the initial rhythm did not need to be shockable, only the most recent rhythm. And then they also stated patients had to be pretreated with epinephrine and amiodarone, but they did not specify or require specific doses of epinephrine and amiodarone to have been administered. And then for exclusion criteria, they excluded women of childbearing potential, patients with a traumatic cardiac arrest, and anyone who had a known allergy to landiolol or another beta blocker. And so they randomized patients within blocks of 4, 1-to-1 to receive either a 20 milligram bolus of landiolol or placebo. And they chose this dose of 20 milligrams based on previous pharmacodynamic data, which showed resulting bradycardia for 15 minutes with doses of 300 micrograms per kilogram of landiolol. So when taking an average patient weight of 80 kilograms, this averages an average dose of about 24 milligrams. In Austria, landiolol is commercially available in vials of 20 milligrams per 2 ml. So to simplify things, they wanted to use a bolus, considering this was out-of-hospital cardiac arrest, and they wanted to use the vial size of 20 milligrams to just increase the ease and feasibility during CPR and, again, out-of-hospital cardiac arrest. So for their primary outcome, they looked at time from trial drug administration to sustained ROSC. Sustained ROSC was ROSC that was at least 20 minutes long. And of note, this primary endpoint only included patients who actually achieved sustained ROSC. Then looking at their secondary outcomes, they looked at ROSC in general, which was a pooled endpoint of temporary ROSC and sustained ROSC, ROSC under extracorporeal CPR, survival at 24 hours, and a favorable neurologic outcome at 28 days. Favorable neurologic outcome was defined as a score of 1 or 2 on the cerebral performance category scale. So patients either had a full recovery or up to a moderate disability. They still had to be independent in their daily activities. For their safety outcomes, they looked at the incidence of pulseless electrical activity, incidence of heart rate under 60 beats per minute, and they don't really give any further definition other than just heart rate under 60 beats per minute, as well as incidence of asystole within 15 minutes of trial drug infusion. So for statistics, they did a per protocol and a modified intention to treat analysis and primarily reported on the intention to treat analysis. And so this included 4 additional patients, 2 of which who received their trial drug via IO access, 1 patient who was older than 85, and 1 patient where there was a presumed extravasation of the trial drug. They used descriptive statistics, Wilcoxon rank sum test, and Fisher's exact test, and a p-value of less than 0.05 was considered statistically significant. So overall, they ended up including 36 patients, 19 of which were in the Landiolol group and 17 of which received placebo. So when looking at the baseline characteristics, the only statistically significant difference was in age. And so you can see that patients on average were about 14 years older in the Landiolol group compared to the placebo group, which could have impacted any potential outcomes. Then when looking at further baseline characteristics, there was no statistically significant differences in any of these. So I just want to focus on the total cohort for a second and just some things that I want to point out. And so majority of patients, 89%, had an initial cardiac rhythm that was shockable. Most common cause of cardiac arrest was deemed to be a cardiac cause at 89%. And they had an overall high number of witnessed cardiac arrests with a high amount of bystander CPR performed. About 98% of patients had bystander CPR. When looking at treatment characteristics, so this table kind of focuses on some timing, and there's just a few things that I want to point out. So the first thing is here our time from ambulance arrival at the scene and ambulance departure, and then time from ambulance departure to hospital arrival, 39 and 10 minutes for the entire cohort, which is a very long time. And they don't, other than this, they don't give any sort of report of the total time in cardiac arrest. So this could have impacted patient outcomes, but there was no statistical difference between the 2 groups for these outcomes. And then the next thing I want to point out here is the time to trial drug administration and the time to epinephrine administration. So if you look again just at the total cohort, 24 minutes minus 18 minutes means that there was a 6-minute difference between administration of the trial drug and epinephrine. And so they only state that they were giving epinephrine every 3 to 5 minutes. There's no other specific data or information regarding that. But so if we're assuming that they were getting it every 3 minutes, this means that they could have only gotten 2 doses of epinephrine before the trial drug was administered. And so if you recall, a lot of the previous studies had definitions requiring at least 3 milligrams of epinephrine to be administered. And then they don't actually ever report how much epinephrine was administered before giving the trial drug. They only do the cumulative epinephrine dose, which was 8 milligrams for the total cohort. But then looking just again at some treatment characteristics, again, no differences between the 2 groups here. So just looking at the total cohort, most patients were in recurrent VFib as opposed to actual refractory VFib. And then a lot of patients, almost half, were able to receive a second dose of the trial drug. And so they were allowed to be given this after 10 minutes if they were still in refractory VFib. Now moving on to our results. So for the primary outcome of time from trial drug infusion to sustained ROSC, you can see no statistically significant difference, about 39 versus 41 minutes. But again, this was only looking at patients who achieved sustained ROSC. So this is comparing the 7 patients in the Landiolol group and 11 patients in the placebo group. Then when we just look at ROSC in general, we can see overall decreased rates of ROSC, almost half in the Landiolol group compared to the placebo, decreased rates of sustained ROSC, decreased temporary ROSC, and decreased ROSC under ECPR. These are all trends, but the only statistically significant difference was in the rate of temporary ROSC at 5 versus 52%. Then when we look at our survival at 24 hours and our favorable neurologic outcome at 28 days, there was no statistically significant difference between the 2 groups, but there was a trend towards both decreased survival and decreased favorable neurologic outcome in patients treated with Landiolol, with about half of the patients in the Landiolol group surviving compared to the placebo group. Now looking at our safety outcomes, so we saw that Landiolol was associated with increased rates of decreased heart rate and asystole, with asystole being statistically significant. So now moving into discussion, The results of this study are pretty interesting because despite pathophysiologic and mechanistic rationale, there was no clear clinical benefit demonstrated with the use of Landiolol in this study. And this actually contrasts what a lot of the previous studies have found. And so some potential reasons that the results of this study might be different compared to previous studies. So this study, the initial rhythm could be non-shockable. And we saw this majority was still shockable, but they did include patients who had an initial rhythm that was non-shockable. This is the first study looking at Landiolol compared to esmolol, so different drugs with different kinetics. Also, a lot of the previous studies, not all of them, but a lot of them looked at a continuous infusion of their study drug, and the study just looked at a bolus. And then again, as I kind of alluded to previously, a lot of previous studies had stricter requirements for epinephrine pretreatment, mostly requiring 3 milligrams of epinephrine. And here they don't report specifically how much epinephrine they gave before trial drug, but if we do the math, extrapolate, they could have gotten like 2 milligrams max. And so because of the epinephrine pretreatment, along with some other endpoints, we have some limited clinical interpretation. So again, the timing of Landiolol compared to previous therapies, and then the definition of the incidence of bradycardia. So they don't really go into specifics as what they're defining as bradycardia, other than it being a heart rate of less than 60. But if you looked at the results in the Landiolol group, there was reportedly 10 patients who had bradycardia, but only 7 patients who had ROSC. So that doesn't really fully make sense. And they never clarify either how many of the patients who got ROSC, how many of those patients got bradycardia, which I think would be an important outcome to look at. And then again, as I mentioned previously, the median time to ROSC was 40 minutes overall. And so again, thinking back on the half-life of Landiolol being about 3 minutes, kind of difficult to draw conclusions to say that this drug with a half-life of 3 minutes is causing ROSC 40 minutes after administration. And then furthermore, we don't really know the optimal dosing of Landiolol. They kind of extrapolated based on some previous studies, like pharmacokinetic studies. But if we look at the study where they looked at electrical storm, the mean effective dose was again 5 micrograms per kilogram per minute. And so that would be about 0.4 milligrams for an 80 kilogram patient. So that's a lot less than the 20 milligrams that they used here in this study. And then importantly, I think another thing to think about is this treatment setting. So this was looking at out of hospital cardiac arrest. So we don't really know how results might potentially be different looking at like an in-hospital cardiac arrest. So leading into my critique. So strengths, this was the first randomized prospective trial, not just for Landiolol, but for beta-1 receptor selective blockade in refractory VFib in general. So I think that's really important and that's good. And I liked how they used the intention to treat analysis. This is more reflective of the real world, especially in out-of-hospital cardiac arrests. And then I did like that they looked at some clinically meaningful endpoints such as survival and neurologic outcomes. That leads me into my first weakness. The primary endpoint that they chose didn't evaluate all of their patients. It was only looking at a small number of patients who had sustained ROSC. So I think choosing a different endpoint that was including all of the patients might be a little more clinically meaningful. So something like sustained ROSC or favorable neurologic outcomes. And then again, there was the significant age difference between the two groups, which could have impacted outcomes. And then as I discussed previously, they had a different definition of refractory VFib, requiring different amounts of pretreatment epinephrine. And then this kind of leads into the last point of the failure to collect and report some clinically relevant data limits meaningful interpretation of an application of results. So the pretreatment epinephrine, the total time in cardiac arrest, and the definition of bradycardia really limit us here. So from this, the authors ended up concluding that Landiolol 20 milligrams did not lead to a shorter time to sustain ROSC, and patients were actually less likely to achieve ROSC. So they concluded that Landiolol also may be associated with bradycardia and asystole, but noted that favorable neurologic outcome at 28 days was overall low in both groups. Then for my conclusions, so with this dosing strategy that they used in this study, Landiolol did not improve meaningful resuscitation outcomes, such as neurologic status, and instead might be harmful, as almost half the amount of patients had sustained ROSC. So at this time, I would recommend against using Landiolol 20 milligram bolus for refractory or recurrent VFib, since they did end up including both patients. patient categories. I do think that beta-1 receptor selective blockade for refractory or recurrent BFib in general does still warrant future study. I think that future studies should prioritize looking at esmolol, which is more readily available and already has more positive results to support it. Or if we're going to continue looking at landiolol, I think we should use either lower or continuous infusion or titratable dosing of landiolol. And I think it would also be interesting to look at alternative treatment settings to see the use of landiolol under ideal conditions and figure out who the best candidates might be. All right, so that is the end of my presentation. Thank you all so much for listening. I am happy to accept any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.